Good afternoon, and welcome to HealthSystemCIO.com's All-Stars panel, Exploring Optimal VNA Migration Approaches, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by GE Healthcare. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using two other WebEx panels today, the Q&A panel, which you can use to send in your questions at any time. Leave the default set to all panelists. I'll be pulling those off to the side and posing them to our panelists later in the program, but you can send them in as they occur to you. We're also going to do a few polls today, so you'll see your polling panel open, and if you want to participate, that would be great. So we appreciate that. And you can see the URL at the bottom of your screen. It's going to go out in the chat box, and it's also at the bottom of our slides to get a hold of the deck. Just so you see how we're going to spend our time today, first we're going to have our panel discussion. We're going to go about 30 to 35 minutes, and then we'll have our Q&A. Our panel is composed of Karen Light, Director of Enterprise Imaging and Diagnostic Services with UPMC, Joe Marion, Principal with Healthcare Integration Strategies, and John Kalafut, Imaging Outcomes and Solutions Leader with GE Healthcare. So we are going to jump right in, and let us start with Karen. Karen, can you give us an overview of UPMC?
Sure. UPMC is a healthcare system with roots in Western Pennsylvania and Pittsburgh. Right now, we have approximately 25 hospitals, many of them level 1 trauma centers. We're constantly growing. We also have a health insurance branch and an international branch where we utilize and set up cancer centers in many areas where there is a need. So that's UPMC.
Very good, very good. Joe, tell us a little bit about your organization.
Sure. I'm a healthcare industry consultant and have been at it for since probably about 1993. I've done a lot of engagements relative to enterprise imaging as well as radiology and cardiology engagements, and primarily focus on assistance with strategy, planning, and implementation, vendor selection implementation.
Very good, Joe. We appreciate you being here today. John, a little bit about GE Healthcare. Oh, I think we lost John for a few minutes, so let's move on. John will join us as soon as he can. Okay. Karen, what functional roles participated in your decision to implement a VNA?
Our Chief Medical Information Officer and our Radiology Informatics Medical Officer were really key in our decision to obtain and implement a VNA. With our environment, we had over 29 PACS instances, and it was very difficult for our clinicians to obtain a unified view of patient data. In addition to that, we were leveraging our radiology PAC system to address a number of the needs throughout the health system, but not related to radiology. For example, dermatology, ophthalmology. We had a lot of these other branches of medicine with a need to obtain and store and reference non-DICOM images, and we kind of were jury-rigging our radiology PACS system to address some of those needs. So growing into a VNA environment just kind of made sense for us. So a lot of the chief medical leaders and also our vice president of ISD, and also our the leaders, the executive leaders in our clinical environments were basically asking for this functionality and wanted us to move in this direction. So.
Okay, you want to add any more in terms of the basis for their involvement, or you think we covered it?
I think I covered it. I mean, it really was the need in the clinical area that drove the health center's decision to secure a VNA and to work towards its implementation.
All right, very good. I think we have John back on the line with us. John, are you there?
Yes, can you hear me?
Yeah, I can hear you. You sound great. Can you give us an overview?
Perfect. Okay.
Give us an overview of GE Healthcare, if you would.
Sure. Okay. Thanks. So I'm part of our GE Healthcare digital business, which is our overarching healthcare IT franchise, which is a significant portion of overall GE Healthcare. Right? GE Healthcare is about a $19 billion global business that provides solutions in imaging, monitoring, devices, life sciences, but also, as I mentioned, our healthcare IT, which is not just radiology, but also cardiology, perinatal, anesthesia, and more recently, our large investment across the corporation, across GE, is to either in businesses like healthcare, where we have a sizable install base and a history of developing and delivering enterprise solutions, how do we marry that with state-of-the-art technologies like artificial intelligence, deep learning, and larger scale analytics? This is where two vendor-neutral archives and broader regional and enterprise consolidation approaches are key to our strategy and our commitment to providing value across the entire care pathway of imaging and other ologies.
Very good. All right, let's stick with you, John, and let's talk about advice as opposed to participated in. What functional roles do you believe should be involved in the decision to implement a VNA?
Sure, good question. It's one that transcends obviously the department, right? I think even implicit in most operational definitions of vendor-neutral archive, which again we could spend probably 30 minutes just on that topic, right? But if you take the approach that a vendor-neutral archive is really something that should augment your institution's data access strategy, it therefore elevates itself to the level of enterprise and even cross-enterprise decision makers. So CIOs, obviously, IT directors, but I think it's also very important, and also from my experience both in and outside of GE, it's having chief medical officers involved, chief medical information officers, because it's not just about having a big database of image data and non-DICOM data, right, but it's more important how do you bring that into the workflows that are meaningful for the end users, which in the context of an image-enabled EMR strategy, it's obviously the care teams, right? It's also remote access to your clinicians at home or that are mobile. So really it's a federated approach to decision-making about governance and access, but more importantly, deciding how and where to liberate these data sets, which state-of-the-art vendor-neutral archive should make accessible to your care team.
Very good. Joe, your thoughts?
I agree with what both Karen and John have said. I think that I would put additional emphasis on the clinical users and their value add to the process, or more appropriately maybe would even be the educational process that occurs. So I've been through experiences where, you know, the thought is, well, we'll just push our images into the radiology PACS archive, and no understanding or sensitivity, if you will, to the patient identification information. So you end up with orphan studies in the archive and a lot of effort to match those up. So I think the sooner or earlier that you can get the clinical people involved, the better that you'll have an understanding of the total requirements.
We certainly hear that a lot, the importance of getting the clinical people involved in most types of IT implementations. All right, Karen, let's go with you here. We got a few questions on this slide. Let me just read them off, and then you could take them as you like. What were the key decision factors by role and by feature function in selecting a VNA? Did your organization identify all impacted services as part of a VNA assessment, or only known areas such as radiology and cardiology? And did you include a universal viewer as part of your implementation?
So some of the key items, decision factors for selecting our VNA, we knew that our image archive was very large and continues to grow very quickly. We also know that at some point we're going to make the decision, and the health system hasn't done this yet, but we will need to make the decision to manage retirement of those images. So we wanted some automation of the image lifecycle management, which our GE VNA offers. We also knew that it was an absolute must that it accommodated both DICOM and XDS data. We did not want to. We were one of the companies that were DICOM wrapping things to put them into our radiology PACS system, and we really didn't want to continue that approach. So we wanted that flexibility. It was important for us that we went with a vendor that could handle the volume that UPMC produces, and we felt very comfortable with GE doing that. We also, for image distribution, we wanted to make sure that we had a zero footprint viewer so that it was something that could be installed and easily managed anywhere. And we also made the decision that we wanted to kind of unify the way we handled our e-record URL links. We wanted them to come from the VNA rather than from the individual PACS system to make it easier in the long run to consolidate PACS systems and to change them out when the need arose. So we looked at all of those factors. We did look at what we believed was all of the ologies that had needs. Of course, as we started down the VNA route, we identified that very quickly as this becomes an offering, the additional needs come out of the woodwork, and very quickly you find that there are other ologies that you never thought about that have needs and have wants and want to be involved in this. So we did learn a little bit about that as we progressed with our work. We did not include Universal Viewer as part of our VNA implementation. We used the Zero Footprint Viewer. However, we actually are changing out our PACS system at the same time that we're implementing the GE VNA. So we are implementing GE Universal Viewer as part of our new PACS application. So we do have that within the organization.
Very good, very good. Joe, your thoughts on these questions in terms of advice?
I agree with everything Karen has said. I think the EHR, EMR integration is a key, and I think that overall I've never been a fan of the term VNA because it's too limiting. It's not just an archive. It is what I would refer to as enterprise image management. So it's the accessibility as well as the storage and management of that storage. The other aspect I think is that if you are looking beyond just DICOM and getting into XDS is the whole question of a federated or distributed solution. So I think as organizations grow and merge and look at a broader database, that it's important to consider the fact of having a common registry, but also the prospect that you may have multiple repositories.
Very good. John,
Anthony,
your thoughts?
if I may just build on Joe's good answer there, I would say just to some practical or real-life advice from working with a lot of clients that have gone through this change process, especially as you're looking beyond just one department, archiving DICOM images, moving into multiple departments, and then to an XDS approach across domains. This becomes a good opportunity to really think about your institution's MPI strategy. So really a key element too of any VNA solution should be how do you reconcile and deal with the issue of, like most real health systems, right, multiple patient information, MRNs. So in some instances, a VNA could be a good forcing function from that IT governance to rectify some of the sins of the past, if you will, right, through acquisitions and having multiple domains. And I'd say as folks are looking to do a VNA purchase and or RFI and RFP processes, really think hard about how do you want to address and handle the issue of multiple patient reconciliation.
Very good. Well, what a segue, John. We're going to stick with you on this next question and talk a little bit more about IT governance. In deploying your VNA, what role should it play in change management?
Sure. No, and this is the key one. This is where I mentioned, too, I think the critical role of a CMIO as well, because it's not just about the IT, the plumbing, and your storage, and high available disaster recovery, business continuity. Obviously, all that plays a pivotal role, especially, too, if your VNA is becoming an element of your radiology piece, right? Because as we all know, PACS is a critical element, mission critical system in diagnosing diseases. Yes, your storage and the IT pieces are critical. But why I mentioned that CMIO aspect is, well, especially as you look at consolidating and bringing together other artifacts that are not just DICOM objects, but whether they're waveforms, whether they're visible light images, you really want to work through with the different care areas to see where is there value. Because you could argue just sticking everything into a VNA is not necessarily a governance model, right? So I think it's that key coordination and thought process amongst not just the IT stakeholders, but the medical teams, and especially the ologies or the users that are incredibly image intensive, right? Their voices and their needs should be very early on considered and brought into the decision process.
Very good. Joe, thoughts?
Yeah, again, building on what I think John has said is that it's sort of the dichotomy of IT as well as the clinical management input. So it's great if people design around a particular IT infrastructure, but that has to meet the clinical needs. So, for example, if from a disaster recovery or business continuity perspective, one is looking at parallel data centers in, say, either a hot or hot-warm kind of configuration, then the question becomes how critical are some of the imaging operations? Do they really need that degree of infrastructure? So could they survive in just in essence, a recovery mode, or do they actually have to have the redundancy in terms of data centers? So I think it has to be a balance between IT's design of infrastructure with what the clinical needs are.
Karen, your thoughts on the question, or either comments from Joe or John?
Yeah, I think they're right on target. I mean, it's very important to work with the clinical owners to make sure that the data is organized in a fashion that meets their needs, to help with rollout strategy, because I think we're probably, UPMC is probably not unique in that a lot of health systems have a growing amount of data to present logically to their clinical decision makers. And it takes some time to implement a VNA. So it's important that the clinical decision makers understand and agree with rollout strategy and agree and participate with the data cleansing that's required to make sure that the archive that is built is clean and presents appropriate and reliable information. Definitely you uncover a lot of the sins of the past and need to correct them as you're implementing and migrating over to your new VNA.
And Karen, I think you mentioned before that different, ologies had come up that you hadn't looked at and uncovering things. So I guess as with any big project, you're never going to know everything going in, and you need some degree of flexibility once you've begun the project. What are your thoughts about that?
I agree with that. We've gotten into several situations where, one PAC system that we're working rapidly on now, it was kind of on its last legs and having problems. So all of a sudden, that PAC system, gained higher priority. Our health system is rapidly growing. So as additional hospitals are in to our we to make sure that we integrate them, that becomes a priority, and that changes. Folks have to work together with the clinical owners to make sure that the priorities being set really are our clinical users' priorities and best fit the overall organizational mission. Rather than just, being something that's, a lot of the things we do are not convenient for IT, I'll be honest with you. It's and that's probably as it should be. We're there to provide the service to our clinical users, and it's up to them to tell us what they need and what they need first, second, and third. So it's our job to respond to that. So.
Very good. All right, now we have time for our first poll. You should see it open to the right-hand side of your screen now. Have you implemented a VNA for your enterprise? And this is an anonymous poll. Yes, we're implementing it this year, or we're going to, not this year, but the next 2 to 3 years, or no plans yet. So take a moment, answer that poll, give us a nice discussion point, and we're going to go on to our next question while you're answering the poll. Okay, next question, and let's stick with you, Karen. What functional roles participated in the actual VNA implementation plan and execution?
Our IT, definitely, we have an IT team that is dedicated to the VNA. There's, as far as the decision-making as to what goes first, second, and third, that's our clinical leadership. Our Chief Medical Information Officer plays a big role in that to prioritize the needs of our physician. We have a data quality team that we've become best buddies with as we work through migrating data over to populate our VNA. We work with that team to do the data cleansing. So they're a big part of that, and truthfully, they're a team that, unfortunately, at the beginning we didn't realize how important they would be. That's one lesson learned for me. We had to upstaff that, add additional resources to that team, and that's something that we did not think of early on. We've also, to make sure that our data stays clean, we've also made changes and worked with our operational folks. Some of our ologies didn't necessarily follow best practices for data entry and keeping their data clean and to match it up to make sure it was clean. So the IT team worked with that, and even some of our, like, you know, say radiology worked with ophthalmology to, you know, cross-pollinate best practices and work together with things. So definitely a lot of different teams participate as you implement the VNA. Our data governance group is responsible for the organization's data definitions and OIDs. So they play a big part of interacting with us and helping to build our structure, the structure of our data out. So.
Very good. Joe, how should it be, in your opinion?
Well, I agree with what Karen said. I think she's covered the majority of leadership involvement. The one role or functional area that perhaps maybe gets overlooked from time to time would be the legal input. So in terms of ensuring that the correct information is being kept, or all of the information that's needed from a legal perspective is being retained. I know, for example, University of Wisconsin in Madison, that was a huge issue with them as a teaching institution. Their legal department said we really need to be keeping all of the information as opposed to the normal 7-year retention or whatever. Just from a teaching perspective, they wanted to maintain all of it. So I think those types of considerations in terms of involvement are important as well.
Very good. John, any further thoughts?
No, I think those are all, I think those are excellent answers. I guess maybe something to throw out that's a little bit different and builds on the last topic was to think about even beyond your institution, right, but in terms of regional networks, especially I think for a lot of your audience, Anthony, CIOs who are now thinking about, or the, this whole clinical integrated network term has kind of come around again in vogue. But for our experience, especially in GE, with a lot of global customers, we have a lot of regional enterprise networks of image management systems, right? So I think an interesting both governance and functional roles to think about how could your VNA serve as a way to plug into a regional health or a population health strategy that combines multiple facilities and institutions.
Very good. All right, let's look at the poll results. I'm going to share them with the audience now. So, John, let's ask you. We've got 30% said yes, they've implemented. 25% are implementing this year. 20% the next 2 to 3 years, and 15% no plans yet. Pretty spread out, pretty evenly. Is that what you expected?
Yeah, actually, A surprises me a little bit more, right? We know, if you look at market data and just also anecdotal experience, right? We know that that this is a very much a growth area. So I'm actually heartened to see that a lot of folks have gone the route. But then, the rest of the responses sort of fit within the mental framework or the understanding we have and see in the broader marketplace.
Joe, any thoughts on the survey results?
Well, I think it's probably pretty much in line with thinking. I'm, again, pleased as John in the context of how many are either there or getting there. I think that the one differentiator for that is that if you ask the question about a VNA, you specifically said VNA for your enterprise. I think that that's the anomaly, is that a lot of people have implemented VNAs for maybe radiology and or cardiology, and it's not truly an enterprise level of effort as of yet. So I think if one refined the questions, one might find that there are more departmental type solutions than true enterprise solutions.
Very good. All right, let's go to our next question. Karen, let's go to you on this one. What unexpected challenges did you encounter? We touched on a few of them in the VNA migration process, and how did you work through them?
Yeah, the first one was the level of effort involved with data cleansing. Definitely, you need a team of people to comb through the data, and what we do is most of the PACS system works with local medical record numbers. Some of them were implemented in manners that kept data up to date. Others were not. And as health systems join our organization, we find a variety of diligence for keeping the data clean, and then we bring them, clean them, and bring them onto enterprise standards. So, we run it through our data team with our EMPI solution, and make sure that we can reliably match the data. A great point, I think Joe brought it up about legal. Our legal team is involved with us because the data, there always is with us a portion of data where we cannot reliably match what was in the PACS if they haven't kept it pristine, and we can't say for sure who that patient might be. We don't, and what we've chose to do based upon our legal advice, we don't abandon that data. We bring it over, but we put it in what we call a historical archive, so that it's not readily available. We could access it if we need to, but it's not available just for search by physician because we can't know for sure the identity of the patient that belongs to those images. So we have worked through things like that. We actually went a little bit in a wrong direction when we first set up our VNA. We thought that we took the care that we needed to set up the archives, and we made the decision to set them up based upon local medical record numbers rather than our EMPI number. As it turns out, that was not the optimum direction to go. So we're now in a process of working to collapse those local medical record number archives into our EMPI-based archive. We also wavered a little bit from our desire to have the URLs come consistently from the VNA. We have a couple custom applications that way of handling things just became untenable. So we have a few custom UPMC applications that still send out their URLs. We also ran into some issues with file storage requirements and for our storage solution, we had to purchase additional newer storage solution for our new PACS and our VNA. And our storage needed an update, basically. And we have very nice new storage now. But that was an unexpected challenge when we first began the project. So.
Very good, very good. All right, let's go with Joe. How do you best estimate the implementation effort and planning time required for VNA migration?
Well, I think you have to understand all of the interfaces that are necessary and ensure that there's correct time and budgeted effort for those interfaces to things like the EMR and other, if you have other HL7 or FHIR or other interface initiatives. I think that one has to look at what type of configuration you're going to support. So in terms of whether it's federated or distributed, and how one spreads the costs over that. and then have a realistic time frame. So, you know, it's great to estimate things, but you sort of have to build some contingency into that as well.
John?
Yeah, it's without the, I think the right rigor and expectation setting and all that pre-work, migration could very easily turn into a decade-long project, right? So it's again all going to kind of depend on that plan and what's the intent and who's going to, you know, who's really going to benefit, what care area and what sequence.
Karen, thoughts on estimating effort and planning time?
Well, I think that the key for us was getting a handle on our sweet spot for migration. We have about 1.2 petabytes of data to have to migrate, that we want to migrate over to our VNA. We're currently about 30% done. 30% through that. We get, we're able to put through about 5 terabytes a week for the historical migration. So it does take some time. So we've been at it probably about a year and a half now, and we're a little over 30% done. So, but you know, the effort is worth it because it will help us in the long run, not only to have a unified database and to be able to present an integrated patient view, but also, you know, we can reduce the storage on the local PACS system and leverage our VNA, the more historical items. You know, it takes some time and effort, and it's definitely something that if it's done right, the data cleansing takes probably about as long as it takes to get the data migrated over there. That, from my experience, that's what we were faced with and what we've found as we work through with our solution.
All right, very good. Let's go with our next poll, and we're going to open it now. And this would be for folks who either have implemented or are planning to implement. What do you expect to include with your VNA? DICOM images only, DICOM images and documents, DICOM images and XDS documents, DICOM XDS visible light capture, or not sure. So if you can go ahead and answer that, we would truly appreciate it, and we will take a look. At this point, I want to get to a couple of audience questions. So let's do that. One moment, please. All right. Let's see. It is assumed that XDS means keeping the organization's internal content distributed between, I'm sorry, is it assumed? Is it assumed that XDS means keeping the organization's internal content distributed between servers, or is it realistic to bring that data into the VNA storage? Joe, who are you on this one?
I think it's realistic to bring it into the common storage, but again, I think it depends on what the context of that question is. So I think the fundamental aspect is that there's a common registry, but there could be multiple repositories of the information. So it doesn't necessarily all have to reside in one place as long as there's a common registry and a means of getting to that information.
John?
Right. No, Joe took this all right on my head. Right. I say, yeah, that gets back to your data, even your data modeling, your institutional approach. Right. Do you want to federate, or is it worthwhile bringing everything together? But yeah, it's the function of what's most optimal for both your, I would say, your network topology and also your users and where and how you want to access those data types.
Karen, any thoughts on that question?
I agree with Joe and John, and it might vary. It might not be, for example, like the visible light images. We have melanoma screening that are full body visible light images, and those we have extra security and extra protection around those images. It may not be, all visible light images are captured that way, but, there's ability to, based upon clinical need, make those types of adjustments.
Okay, very good. Let's go back and share the poll results. And interesting thing here to me is we see 23% said DICOM XDS and visible light capture, 10% not sure. The other numbers are small. So, Joe, your thoughts on people including the DICOM XDS and visible light capture?
Well, if you're going to get to a true enterprise archive, you have to have the ability to do that. So I'm pleasantly surprised to see that it's close to 0.25%.
So that makes sense. That makes a lot of sense. John, does that make sense that most people are including all those things?
Same thing, yeah, and I think it's a good reflection too of the community's overall approach and messaging over the last, let's say, 5 years. I mean, if you asked this question 5 years ago, it'd be a very different response. So I think this is again very encouraging, and also too, it underscores, I think, the broader opportunity that a VNA has as we try to demystify or put some real definition behind what is value-based imaging. Right, this is a kind of a key foundational solution if you're trying to get, especially the imagingology like radiology, out of the dark rooms, if you will. So this is a good indication.
Very good. All right, Karen, we have an audience question for you. Did UPMC try to bring all the historical studies into the VNA, or did you just put new studies on the VNA?
We're actually all of our historical studies over, and that's probably a lessons learned because we started, we've coined the phrase donut hole at our organization because we started from, the beginning of 2000. We started that migration backwards, and then as we bring up sites onto our new packs, we start them forward. So say they come live at the end of May 17, we have that gap between, May the 1st and or January 17 and May the 17. That's our donut hole that we have to catch up as we bring new sites live. And the problem that we're facing is that since we have so many hospitals, we can't naturally bring them live all at the same time. So we're kind of constantly battling this donut hole between our start of their historical migration and when we bring them live. So I don't think that we have a good solution for that yet because we want that historical data over there in addition, to working on moving our sites forward. But I'm open to others' inputs if somebody has a good way to do that.
All right, very good. We'll go back to our questions. We have about 5 more minutes here. Karen, let's stick with you. What are the best practices for post-migration problem handling, communication, and, of course, celebration?
You have to celebrate the victories. Definitely, I think that's the most important thing because it's a lot of work especially getting the migration up. The post-migration problems, really, it's just keeping track of them, being tenacious with them, not giving up, working towards the best solution, pulling in the group. When we started, my teams are used to this. I always tell my teams, and I follow this rule too, no one of us makes a decision singly. We have, as a group, to make sure that we've thought through all possible options, and we've come up with the best option. And that includes not only the IT group, but we pull our clinical owners into that and our physicians into that, so that, you know, both as we're making the decision going forward, and then if we encounter a problem, we pause and bring everybody in to, you know, figure out what the best thing to do from there is to handle it. Communication is key to keeping your clinical users apprised of progress on the project, and to set realistic expectations, because migration does take time, and when direction changes, everybody has to be on if direction is going to change with work expectations. So, you know, just do it together. If you're together, it'll be successful.
Joe?
Yeah, there are a couple specifics, I guess. I'm a stickler in terms of acceptance test criteria and the inclusion of that and making that a living document. So having good acceptance criteria and being able to use that to avoid any discrepancies down the line. And I think that plays into the notion of continuation of planning. So anybody that's looking at implementing this kind of technology really needs to be looking at sort of a 3-year plan so that you have some leeway in terms of planning for capacity as well as any contingency for overcapacity, and then making sure that if one includes a universal viewer, one of the challenges is going to be is that all of the service lines understand how to use that. So I think it's imperative on the part of the informatics groups to be present in those areas when they go live so that they can help address any questions that come up in terms of the use or interaction with the system.
John, I'll give you the last word.
Sure, right. I think that also is reflected, again, when I look out with the, you know, sort of broader lens of institutions. I think a governance strategy, even leadership-wise, in terms of how do you ensure your IT service lines are more harmonized in a true enterprise imaging approach, right? So it's not just the radiology team or cardiology team that's going to be responsible for this, but especially as Joe mentioned, right, as you bring out the universal viewer to your clinical base, making sure that frontline support, your help desk, your infrastructure team, everybody understands that this is, you know, a little bit different, say, than handling a flow sheet, you know, debugging problem. And so I think having that you know, IT and service line harmonization around an imaging strategy is a key ingredient for success.
Very good. Well, that's about all we had time for today. When you close out your WebEx window, you'll be taken to a post-event survey. If you could take a moment to answer that, we would appreciate it. For those of you with continuing education interest in our events, today's events gets you 1 CEU towards the CHIME CHCIO certification program, so let CHIME know you were here. And if you've asked us to do so, we certainly will. If you need a certificate of attendance for another CEU program, you could use the final slide in this deck. You'll receive an email when our archive recording of this event has been posted to our YouTube channel. If you'd like us to produce a webinar for you, you can reach out to Nancy Wilcox on our team. You can go to our website to see our upcoming schedule. So with that, I want to thank our panel, Karen Light, Joe Marion, John Kalafut. I very much want to thank GE Healthcare for making this event possible. And I, of course, want to thank you, all our attendees. Everybody have a wonderful day. Thank you.
Thank you.
Bye-bye.